do you have like some key metrics that you look at?
What you're talking about there is it's on an aspect of quality, which is a personally defined standard. Personally defined standard. Everyone has different standards. Like, well, I don't know if that is the correct way to say everyone has different standards, but there's a variability in what people expect from a service. What good looks like. And so that's a nice segue into or I think we should look at that within the broader context of a framework for quality, so we can interpret that and look at quality from a variety of different angles. And at some point, we will get to this KPI question of how does that fit into monitoring attainment of standards within a quality assurance framework. When Robbie, as I was mentioned, when Robbie and I launched some research, it ultimately resulted in a paper published in, I think it's 2022, in the Behavior Analysis in Practice. And I forget the actual title of our paper, but it was Exploring Quality in the ABA Service Industry, something like this. And what we wanted to do is sample from sources in ABA research and ABA practice how behavior analysts are talking about or conceptualize quality. So we could sort of start a conversation about, well, hey, there's considerable variability in how we talk about quality. Quality actually is underrepresented in research in our peer-reviewed journals. And so probably a lack of consensus on a definition of quality and an ability to operationally define quality is a barrier to the industry being able to objectively and verifiably sort of monitor quality over time and manipulate or design, I would say this way, design service delivery systems that enable clinicians, clinical directors, operators to engage in those practices necessary to meet standards and deliver and understand the variables. What are the variables that are influencing quality service practices? So that now, because we didn't have an evidence base. There wasn't there's a huge evidence base for 70 years building on the validation of behavior change procedures and assessments, but very little research validating the systems and the context that support practitioners using those validated procedures and assessments over time, to the satisfaction of other people based on their personally defined standards, So now I'll go back up a little bit. Okay. So in the paper, we said this, okay, here's a starting point. You can define quality, at least at the organizational level, as the extent to which an ABA organization meets professional and consumer standards over time in response to a receiving system. This is the recognition that there are external factors and contingencies in a macro system or a market that have an influence on what we do in any given organization. And then attaining those standards over time while surviving challenges in the marketplace to keep your organization thriving, but also maximize financial health over time. And the focus on that is really about the ability to continue to invest in quality assurance over time. It's not about the biggest profit. Sometimes when I first published that paper with Robbie and I started giving talks, they're like, why is this tied to profit and whatnot? And I was like, wait a minute, that's not the point here. Actually, we're talking broadly financial health is you have a healthy profit margin, a healthy, stable revenue streams, and you have a responsible growth over time in the investment in quality assurance. So you have operational goals and you have clinical quality goals, and both of them are receiving investment and attention, and they go together instead of one shooting off. Yes. And you have rapid, uncontrolled, sort of unreasonable growth in operations while quality lags behind. So that's been a starting point, and that's been sort of an anchor for everything that I've done in quality in sort of research and practice since.
Yeah, I like how you say the company has to be sustainable. There has to be some profit in the company so you can reinvest. And so what I assume, like you said, when you started talking about this, there was some pushback. Whoa. We had to focus on quality clinical services. Why are you bringing up profitability of my company in this, right? That's evil. That's bad. Can you talk more about that?
Yeah. I will say that I'm not a finance guy. I'm not a financial health of the organization is not my expertise. My expertise is more focused on designing the systems and the processes within a quality assurance system. And one of the things I'm learning is that it is difficult to draw a direct line between, let's say, like quality assurance initiatives or quality improvement initiatives and key business results from a financial perspective. It's tough because what I found is if you have a robust quality assurance system, like a quality management system that is developing across your organization, it happens as a result of everyone starting to feel like quality is everyone's job. Everyone has a role. Everyone plays a part. And no matter where you are in the organizational chart, you do have influence on service quality, especially with respect to what's exactly right in front of you. There are constraints the systems place on you, but you do have control over the quality of your interactions with other people and the outcomes or the work outputs of whatever your responsibilities or tasks are. You have a degree of control, and we can it'd be fun to talk, double click on this later. But in the quality field, there are fundamental principles of managing for quality that anyone, anywhere in an organization can apply at any time to everything that they do. So I think that's a useful concept to apply. But yeah, you end up having, to build a quality assurance system, you end up having quality improvement initiatives that focus on often process improvement. And that happens through cross-functional teams where you have, meaning people from different departments. In order to improve, for example, a training process in an ABA organization, you may have to work with the training team, but the clinical clinicians who are the recipients of the trained technicians, but also the clinical director, and then HR and recruiting and people from other departments, because everybody has a different perspective. And also, there's this general underlying philosophy in quality, in the quality field outside of ABA, that everyone's a customer. Your client is not the customer. They are a customer. And if you are training technicians in your organization, the receiving system, the service delivery system where they go out of training and into direct treatment with clients in maybe a two-tiered model supervised by BCBAs, those BCBA supervisors, they're customers. They're receiving an output from a process and expecting they have a standard. The organization has a standard, maybe. And then the clinician has a standard for what they need to get their job done. And the technician has a standard.